સારું રહ્યું, વેલ મેનેજ્ડ.
સાહેબે જોઈન કર્યું. એકચ્યુઅલી મારે કંઈક ઇન્ટરનેટમાં ઇશ્યુ આવી રહ્યો છે, ઘરે ઇલેક્ટ્રિકનું કામ ચાલે છે. Good morning, Dr. Khiria.
Good morning, sir.
Hello.
Hello.
Yes, thanks for joining early on. We are still waiting for, I think Dr. Pankaj Modi sir should be joining anytime soon.
Okay.
And from Dr. Yogesh Harwani, I think he will be joining, or one of his Dr. Harshal Patel will be joining. Just give us a moment.
Hello, sir. Good morning. I'm Dr. Harshal Patel.
Oh,
Harshal is
bhai.
there, I can see. Yeah.
Okay, fine.
किरिया साहब दाढ़ी सरस सूट करे.
Thank you, sir. मुझे लगा आप लोगों के साथ आने के लिए थोड़ा तो मेरे को सीनियर बनना पड़े ना.
यहाँ नहीं तो यहाँ व्हाइट होनी चाहिए.
White होनी चाहिए.
यहाँ है तो चिंता नहीं है.
सही है. आप लोगों के साथ आने के लिए थोड़ा तो मेरे को.
Good morning.
Good morning, sir.
Good morning. How are you? Lakshman.
Good. Sir.
Hitesh, good morning. Bye.
Good morning સાહેબ, કેમ છો?
બસ મજામાં. Good morning, Nina Ben.
Good morning, sir.
Good morning.
સર ચાલુ કરશું. આજે we have a case of obstructive jaundice. ડોક્ટર નીનાબેન અને હિતેશ અંધારિયા સર આપણી જોડે છે, અને ડોક્ટર હર્ષલ પટેલ ઇઝ અ gastroenterologist, DM gastroenterologist from Noble Gastro Hospital, and Dr. Lakshman Khiria from Apollo Hospital as a gastrosurgeon is available. અને we will be joined by Dr. Deepak Patel sir. એક નાનું સેશન regarding reading of CT scan. આ જ પેશન્ટનો CT scan છે in a case of periampullary malignancy. એટલે સાહેબે કીધું છે કે જોઈન.
Okay. Good morning, Harshal.
Sir, good morning. Good morning. Good morning, sir.
Okay. Shall we start then?
Yes, sir.
Okay.
Lavesh. Hello.
Hello.
ક્યાં ગયા બધા? હા, દીક્ષિત.
Yes, sir.
લવેશ કેમ ગયો? કોણ પ્રેઝન્ટ કોણ કરી રહ્યું છે?
Sir, મારું
It is
અચ્છા, તારો
Dixit.
turn. Sorry. Sorry.
અલા અપૂર્વા, આવું કેમ ચાલે?
Sorry, sir.
Busy person, bhai, on vacation.
એને એ જ કીધું ચાલુ દિવસે રાખ. તો કે સાહેબ ચાલુ દિવસે બહુ હેક્ટિક હોય. મેં કીધું ચાલુ દિવસે જ નવરો હોઉં છું.
હવે હું તો સાવત નવરો થઈ ગયો ને ભાઈ. Retired.
Hello.
ચાલ.
Good morning, everyone. My name is Dr. Dixit, third year general surgical resident at Civil Hospital, Ahmedabad. I am presenting case on obstructive jaundice. under guidance of Dr. Pankaj Modi sir, Dr. Apurva Shah sir, Dr. Vinit Chauhan sir, and Dr. Dr. Hiral ma'am, and Dr. Maulik Mehta sir. A 50-year-old male patient residing at Ahmedabad, driver by occupation, from low socioeconomic class, present to Civil Hospital Ahmedabad with chief complaint of yellowish discoloration of eye and urine for 1 month. Patient was relatively asymptomatic before 1 month. Then he noticed yellowish discoloration of eyes and urine, which was progressively deepening, associated with loss of weight, approximately 10 kg in 1 month, associated with anorexia, pale stool, and generalized itching, not associated with abdominal pain, fever, nausea, vomiting, lump in abdomen, no passage of black color stool, blood in vomitus, no altered mental status, no history of blood transfusion, no history of diabetes, hypertension, and tuberculosis, no past history of jaundice, no previous surgical history. Patient is taking vegetarian diet, decreased appetite, having altered bowel and bladder habit, and sleep is adequate with no addiction, no any significant family history. A summary of history: a 50-year male patient presented with progressively deepening yellowish discoloration of eye and urine for 1 month, associated with anorexia, loss of weight, clay color stool, and generalized itching.
Okay.
दीक्षित भाई, पहली स्लाइड पर जाओ, पहली स्लाइड पर
First slide. Go to first slide, Dikshit.
Yes, sir. Yes, sir.
just a suggestion.
Start.
No, I am not right now doing any criticism. When you write down a 50-year-old male residing at Ahmedabad, driver by occupation, તારી 1 second બચાવવા માટે by occupation you can remove. From lower socio-economic class you can remove. Driver cannot be from high affluent class unless in Canada, right?
Yes, sir.
And driver
Yes,
is an occupation. So just say driver, that is enough. Minimum
Yes.
use, giving maximum output, just to save your 5 seconds, which will able to allow examiners to ask one question and which can decide whether you are in distinction borderline, right? Just a
Yes.
suggestion for all PGs attending. Minimum use of words and headings in your history presentation. Go to next. Another thing, yellowish discoloration of eyes and urine. See, ODP ma there can be only one observation probably, which was what is first noticeable thing, urine discoloration or eyes in general.
Yes, sir. In first eyes, then urine, sir.
Are you sure?
Wrong.
Are you sure? પહેલું શું,
Yes,
પહેલી
sir.
આંખ જોશે કે યુરિન જોશે? Usually it may be eyes sometimes. I don't disagree, but you should mention, he mentioned discoloration of urine, and then someone told him that your eyes are also yellowish. This looks more sensible. It may be other way around, but you must be very sure that what appeared first, right? Next slide.
Yes.
Then we will again come to history. I'll just point out few points which I noticed at a glance. Okay, this point we discussed. Next.
Yes, sir.
Again, next. See, again, everybody mentions no history of diabetes in past history. Diabetes cannot be a past history. Hypertension cannot be a past history. Yes, tuberculosis can be. So you should mention a word comorbidity. Now we are in PG, probably going to become super specialist after completing MS. So there is no comorbidity like diabetes, hypertension. There is no history of tuberculosis. This is what you can say. When you mention the heading past history, someone, I don't mind, someone will say, Doctor, is diabetes a past history? And you will waste your timings, right? Here we have 2 hours. Probably in exam, you will have half an hour maximum, right? So these are the few points these are very simple points, but you should remember. Next.
Yes, sir.
Okay, now you can go to first history and we can start academic discussion de novo.
Second slide. Yes. Lakshman,
Yes,
want
sir.
to say anything?
This is normal, sir. Fine. I'm
Fine.
okay with it.
The point here is that what does the history tell you? From this history, what do you suspect?
Sir, history of jaundice with pale stool
What
and
was the
generalized.
question? Dixit, what was the question?
I am not asking, you are giving explanation
What was
first
the
and
question?
answer later.
What was the question?
What history suggest?
What does it
just tell us
suggest?
what does it suggest? Probable
Uh,
probabilities or probable diagnosis?
Obstructive jaundice, sir.
Probably because of. See, you
Uh,
should be as clear as in your mind as any of examiner has to be, because tomorrow you are going to become MS. So from this history, I am suspecting obstructive jaundice probably due to malignant obstruction. This is what you can say. Let examiner ask. There are few examiners, depending upon your confidence, they will say, I am fine with it. You know why you are telling your diagnosis. So they will not ask you further question. That will open up another doors for questions, right? So from this history, what are you suspecting? Obstructive jaundice, probably due to malignant obstruction. This is what you should say.
And let the examiner ask you, why do you suspect obstructive jaundice? Let us discuss that. Okay, we have already discussed the points which are that. Why do you suspect it is obstructive jaundice? From history.
Yes, sir. Because of jaundice associated with sir pale color stool and generalized itching, which suggests sir obstructive jaundice.
So what do you mean by obstructive jaundice?
There is a obstruction in bile flow to sir gut, sir, duodenum.
That is the obstructive jaundice. So by definition, what is obstructive jaundice?
There is obstruction in bile flow, sir.
At which level? When will you call it obstructive jaundice? Do you understand my question?
Yes, sir. Sir, extrahepatic biliary system.
So wrong. That is not. Yes, Dinaben, you want to say something? She has gone. So it's wrong. What is definition of obstructive jaundice? You have put a diagnosis of obstructive jaundice. Do you understand my question?
Yes, sir.
મેડમ ના ઓડિયો માં કઈક ઇશ્યુ છે મેડમ બોલે છે ખરા પણ
અચ્છા સંભળાતું નથી. ઓકે. Yes.
Sir, there is when there is obstruction of bile flow from intrahepatic biliary radicals to extrahepatic biliary radicals, then.
Hitesh bhai, would you like to add something? That's why you were trying to explain first and answer that is. So whatever you speak, you should be very clear what you are speaking. You have said obstructive jaundice. So what is it? Let us go back. Very simple question. What are the types of jaundice you know?
Yes, sir. Sir, prehepatic, hepatic, and sir, post-hepatic.
This is another problem. What did I ask you?
What are the types of jaundice?
Jaundice. Are they prehepatic?
MBBS. Don't think that you are a surgeon.
Understand the question. That's why it is a learning process, but understand. What did I ask you? Types of jaundice. I am not asking you but that is, what are the types of jaundice? This is a very basic question. Anybody should be able to answer it.
Yes, medical jaundice and surgical jaundice.
Acha, what is medical jaundice? No, again, you are wrong, actually.
See, we should not decide how we refer the patient to medical department.
There can be overlapping also.
Yes, many times the sensible student or doctor irrespective of jaundice to his own department, try to rule out his fraternity and then refer.
So this is the problem with all of the students which I have observed. They read so much about surgery. If you ask, they will say about Whipple's, chemotherapy, tumor marker, this, that, what not. But you should be able to reach there to answer those questions. The first question is, there are usually time immemorial, it has been said, it is infective, hemolytic, and obstructive. Do you understand? So yes. What is infective hepatitis? Or which can lead to jaundice? Types of that?
Yes, sir.
And there are subtypes also which will fall in an obstructive also that we'll discuss later. So let us discuss this. You need to learn this rather than to learn Whipple.
Yes. Sir, viral hepatitis.
Very good.
Yes.
It can be hepatitis A, B, C, whatever it is, right?
Yes,
There
sir.
are other also. Then comes the hemolytic. What are the types of hemolytic jaundice, you know?
Hemolytic jaundice due to hereditary spherocytosis.
What is
Because of
why they are known as hemolytic jaundice?
What do you mean by hemolysis?
because of RBC breakdown
Early,
occur, which lead to increased bilirubin production.
not production.
Production not high.
Why this happens? We have not thought of these questions, right?
That is the problem.
So try to teach these things to your juniors. Then you will remember. Why we remember? We are asking repeatedly. There is no rocket science. So try to discuss this in your rounds. The problem is, as soon as jaundice comes, without even putting hand, asking history, we refer to USG. And then we decide whether to admit or not. This is the problem. In general,
Remember,
not with you only. In general.
Exam is not about what you know. Exam is about what you don't know. So you are so sure it is obstructive jaundice, but why it is obstructive jaundice? So hemolytic anemia, there is excessive hemolysis of the release of heme, which is converted into bilirubin and biliverdin. So there is an increased load because of increased destruction, which gives rise to hemolytic anemia. There are various type causes are various, will not go in detail for that. Remember, so that is the thing. And third is obstructive jaundice. There is a kind of obstruction.
Dixit bhai, can there be hemolytic jaundice along with obstructive jaundice? Give me one example, if you know.
Yes.
Yes, sir. In hereditary spherocytosis, there is a hemolysis occur along with sir cholelithiasis occur, sir.
Don't stick to hereditary spherocytosis only.
Yes, sir. In all hemolytic anemias.
There can be possibility of pigment, right?
Yes, sir.
Then what happens? How do you explain obstructive pattern there?
Then, sir, migration of stone from gallbladder to
carry on. Exactly. This is what logic tells you to speak. Very good.
So there is a one more pitfall you remember. Do not confuse obstructive jaundice with surgical jaundice. What you are saying, stone is formed and then there is obstruction. Does it remain hemolytic jaundice or does it become obstructive jaundice? So there are two things. What actually meant is there can be obstructive jaundice without surgical jaundice. There can be a surgical jaundice without obstructive jaundice. So sir wants to ask which are the causes where there can be a surgical jaundice but no obstructive jaundice. Give me the example.
Sir, hemolytic anemia, sir.
Not all hemo. You are going so generalizing. All hemolytic anemia surgical jaundice? No. Some of them, like where a jaundice can be treated surgically. Fine. Right? Give me the example of obstructive jaundice without surgical jaundice. The original question was here.
What is cholestatic, the other word?
Yes.
Yes. Yeah.
Yes, sir. Cholestatic
Your
jaundice.
teacher has given
He
you
is
a
your
hint.
internal examiner. He is your internal examiner.
He is internal examiner. I have become now external. Yes, Dixit?
Yes, sir. There is a stasis of bile flow.
Examples?
Example, cholestasis occur in sir pregnancy.
No. Where at which level? That is important. The cause is the next question. You are going one question further. Hint you are unable to take. Intrahepatic cholestasis. That should be the answer. Do you understand? Causes may be not only pregnancy. It can be drug induced. It can be so this and that. Do you understand? And that is obstructive jaundice, but not amenable to surgery. So when you use the word obstructive jaundice, it is a stasis of bile, intrahepatic or extrahepatic. That is the word you should understand very clearly. What is the problem with all of us is that obstructive jaundice means CA or stone. There are not only two reasons. There are so many other reasons for that. Yes.
Okay,
Please.
tell me, why do you say it is obstructive jaundice? From history.
That is the actual question was this.
Yes, sir. The history
Just
of
relax. Just relax. Be as confident as you were from word go. Don't get any distorted.
Sir, history of pale stool and generalized itching suggestive of, sir, obstructive jaundice.
No, first you should say it is jaundice. First, there is history of yellowish discoloration of urine, eyes, as well as patient presents with itching, generalized itching, and pale color stool. That is why it suggests that it is obstructive jaundice. Now I'll ask, why do you say it is malignant obstructive jaundice? Then you should answer the further lead. This is how you should think. This is how you should answer. Why do you say it is probably a malignant obstructive jaundice?
Because, sir, there is a loss of weight, approx 10 kg.
No, always begin with age.
Yes, sir.
Always begin with age. Right? Is he alcoholic?
Sir, no, sir.
No. That again gives two channels to discuss. So, 50-year-old male, then
Sir,
symptoms of obstructive jaundice associated with loss of 10 kg body weight, right? Probably.
Yes,
and pale color stool, probably suggestive of obstructive jaundice. Pale color stool is obstructive jaundice only most of the times. Itching can be present in any obstructive jaundice, right? This is a weight loss, again, is a feature of malignancy. This is how we should think. Okay, carry on. Next slide.
Yes, sir.
Lakshman sir, input.
Yes, sir.
Yes, sir.
Hello.
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 Yes, sir.
We are hearing you. Lakshman, please. Are Harshal. Harshal, please.
Sir,
Yes.
I think Lakshman bhai છે, Lakshman sir છે.
ના હર્ષલ છું, ડોક્ટર હર્ષલ.
Harshal is asking. Yes.
આપણે જ્યારે પણ સર આપણે કોઈ પણ પેશન્ટની હિસ્ટ્રી લઈએ ત્યારે ડ્રગ હિસ્ટ્રી યુઝ્યુઅલી બહુ ડિટેલમાં નથી લેતા હોતા. પેશન્ટને આપણે પૂછીએ તો ઓપીડીમાં મોસ્ટલી કોઈ બીજી દવા ચાલે છે તો દે ઓલવેઝ સે કે ના નથી ચાલતી. બટ વેન યુ સ્પેસિફિકલી આસ્ક કે શુગર બીપીની દવા ચાલે છે તો કે હા. એવી રીતે એ લોકો રેગ્યુલર દવાઓને દવા ગણતા જ નથી. તો ઓલવેઝ ટેક હિસ્ટ્રી ઓફ એન્ટી એપિલેપ્ટિક્સ, પર્ટિક્યુલરલી આયુર્વેદિક દવા, હોમિયોપેથિક દવા, કોમ્પ્લિમેન્ટરી અને અલ્ટરનેટ મેડિસિન એ મતલબ વી શુડ આસ્ક અબાઉટ. બીકોઝ ઘણા બધા પેશન્ટ એવા હોય છે કે જે કંઈ ને કંઈ આયુર્વેદિક દવા લેતા હોય છે ફોર સમ એલર્જીક ઓર અધર ડિસઓર્ડર. And we are seeing, particularly after COVID, we are seeing a lot of patients hepatitis induced by CAMs, complementary and alternate medicines. So that history has also to be taken.
Okay.
Yes, sir.
Right. So have you asked drug history?
Yeah, yes, sir. Patient not taking any drugs, so I didn't mention.
You should. Why did you ask history of blood transfusion?
Because, sir, hepatitis B virus.
They omitted. That was also not there. You should have omitted.
Sir, because
Etiology.
it's maybe etiology, sir.
So
Hepatitis
that is
B
why
virus.
no history of any drug intake, chronic drug ingestion, you should mention, right?
Why should you take history of drug transfusion? Now tell me.
Blood transfusion mean to say.
Yes, sir. Hepatitis B virus and hepatitis C virus maybe because of blood transfusion. And second thing is blood transfusion may indicate that patient having anemia. Because of that, patient having blood transfusion. So because of hemolytic anemia, there is a history of blood transfusion also present.
I didn't understand last sentence. What did you say? Last sentence.
Yes, sir. In hemolytic anemia, there is a history of blood transfusion suggests that there is a previously episode of anemia in which blood transfusion occur.
How many?
So you mean to say that if there is repeated blood transfusion, you suspect hemolytic disease?
Which hemolytic anemia needs repeated transfusion?
Sir, thalassemia means.
Huh?
Thalassemia major, sir.
Thalassemia. Will it present as a hemolytic jaundice?
Sir, present as a hemolytic jaundice.
Jaundice.
Usually we are seeing those patients with splenomegaly, not with the jaundice. Never.
They don't develop jaundice. That is the point.
Yes, hepatitis B, it's okay. Never. But if blood transfusion is given, within how much hour there will be hemolysis if it is cross match is altered?
Ma'am, sir, ma'am, I don't know.
That's better.
After 24 to 48 hours, there will be hemolysis, not immediately, right? Okay.
Yes, sir.
So jaundice will be after 24 to 48 hours.
So,
Okay.
Dixit, what did you learn from this? That is what I am telling for everybody. Do not get bias. You are biased that I will be asked everything about malignancy. Remember, you may not reach up to malignancy diagnosis also. So, whatever you are speaking, be careful what you are speaking. The sir has asked obstructive jaundice. Why do you say it is obstructive jaundice? That what you have said first thing is a clay color stool. Do all obstructive jaundice will have a clay color stool?
No, sir. In complete obstruction, there is.
Right. So most of the time it is a malignancy, which will have. Obstructive jaundice doesn't mean malignancy.
Yes, sir.
So why do you call it obstructive jaundice? Do you understand my question? So you should be very careful what you are talking. So what you should be saying is a short history. Deep jaundice associated with itching, no past history of anything related to hemolytic or infective jaundice. So probably it is obstructive jaundice. Do not let the clay color stool or even itching in a picture. Do you understand? Do not
Yes.
confuse obstructive jaundice with malignant jaundice. If
Yes.
there is a bile stone, there will be obstructive jaundice, but will there be a clay color stool?
No, sir.
Very rare. So obstructive clay color is not means it is obstructive jaundice. It is advanced obstructive. So when you say obstructive jaundice, short history, deep jaundice, no past history, older patient, probably it is there. Do you understand? Sometimes
Yes.
you will get also idea that patient may have a past history of cholecystitis or severe right hypochondrial pain, repeated attack of jaundice in a short duration, which may suggest stone. Do you understand? So
Yes.
obstructive jaundice, do not confuse that you have said clay color stool, you are through. It's not like that. In other words, what do you mean by clay color stool?
Sir, there is a uh, normal color of stool is, sir, yellowish, and
What
then
did
it,
I ask you?
yes.
What
What
did
is
I
clay
ask
color?
you? Why
What
are
is
you giving me normal color? I know normal color. Everybody know normal color. I am not asking you normal color of stool. You are buying time, I can understand, but that is not an answer. You will feel that he doesn't know. That's why he is dilly-dallying. Did I ask you normal color of stool? Do you
no?
expect that we don't know what is normal color of stool?
No, sir.
So tell me what is clay color stool?
Sir, patients sir tell that color of stool become a
Is
sir
clay.
like cement. Yes, see,
What is clay?
sir, whitish color like.
Yes, pale white stool. Do you understand? So that should be the answer. Why are you giving normal color of stool? That is the problem. It gives the examiner impression that he doesn't know the actual answer. Do you understand? So think before you speak and answer what is all. Do not go forward or backward. Do you understand?
Yes, sir.
So why were you telling me about normal color of stool?
Sorry, sir.
Not sorry. You understand? This is intentionally I am saying this. So it is important. Knowledge is not everything. How to answer is more important.
Yes,
Okay.
sir.
So what is the
What
reason
are the
for
pathophysiological changes when there is a enterohepatic circulation of bile is affected? Because of the clay color of stool. What happens?
Ma'am, uh, there is no formation of stercobilinogen which lead to, sir, ma'am, clay color stool.
No, but what happens into the body? What is the pathophysiological changes?
you have to describe the cycle?
Yes, sir.
Cycle. How does the stercobilin, what is that?
Yes, sir. Bilirubin converted into hepatocyte conjugated bilirubin, then excreted in biliary canaliculum. From biliary canaliculum, conjugated bilirubin uh, 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 go to gut, and in which, because of bacterial enzyme, bilirubin converted into stercobilinogens. And
So is that the reason of clay color stool? That's madam is asking. Nina બેન એ જ પૂછો છો ને તમે?
Yes, sir. No stercobilinogen in stool lead to, sir, pale colors.
Madam, do you want to
It's
add
not
anything?
only stercobilinogen, there is a bile and bile pigments, both are affected. And then circulation is reduced, and because of that, there will be a change in absorption of the all the things, and that will affect vitamin deficiency and all this thing. You have to answer like that, right? So
Yes.
absorption is affected. Okay.
Have you asked history of
Which vitamin deficiency occurs? Which vitamin deficiency occurs because of this?
Vitamin A, D, E, K, ma'am. Fat soluble.
Oh.
You know it. I am very happy. Okay.
Which is most important out of all this?
Sir, vitamin K.
K. All fat soluble vitamin are affected, but the most important is vitamin K. Right? Madam has asked one question. What is enterohepatic circulation?
Sir, there is a for a production of bile from liver, then is goes to, sir, storage in gallbladder, then release in uh, re- uh, uh, during eating. It is released during in sir, gut, and then
Not
bile
eating.
stored.
When you say eating, you should say particularly fatty foods.
Yes, ma'am.
Release
During
fat.
Yes, ma'am. Then there is a absorption of bile salt from terminal ileum into portal vein, then portal vein into again in liver, sir, lead to enterohepatic circulation.
Right. So what happens in obstructive jaundice? That was the actual question.
In obstructive jaundice, sir, there is no bile flow in the gut, so there is no absorption of water-soluble vitamins
Actually,
and
you
fats.
should not use was no bile flow, minimum. Is
Yes, sir. Minimal bile.
totally complete is extremely rare. Yes. Then, so how much is a normal production of bile per day?
Biles are 700 to 800 ml, sir.
Herschel, would you like to say anything about this?
Sir, approximately it equals to the loss is 0.5 to 1 gram per day.
Lakshman, what we are going to say something?
I think he is confusing bilirubin with bile salts.
Yeah. So what is that? Sir has asked very specific. What is that? So what is bile and bile salt? There are two elements, bile pigment and bile salt.
Yes, sir.
Yes.
Bile pigment is, sir, bilirubin, and bile salt is, sir, primary quinodeoxycholic acid, and
Cholic acid. So
Yes,
simply you should use word cholic acid.
yes,
And
sir.
bilirubin and biliverdin. Right?
Yes,
So
yes.
there are two things. Whenever there is obstruction to the outflow of bile, two things occur. One is obstruction to pigment and obstruction to salt also. And both enter the circulation. So what is the effect of circulating bile pigment and what is the effect of bile salt?
Yes, sir. Circulating bile pigment deposit in sclera lead to, sir,
Not sclera.
or sclera and, sir, skin and under surface of tongue.
No,
Soft
what is
palate.
that word we as a PG you should use? Where does it deposit?
Jaundice. Yes.
Yeah? Where does this bile pigment get deposit?
Sir, elastic fiber of
Yes, elastic. So it will be deposited everywhere, but it will be seen where it is exposed, like a sclera tongue, commonly. When it is very deep jaundice, even skin can show little bit of it. Yes, Arshal, you want to say something?
Yes, sir. That's
Yes. Right. So remember, all this bile pathophysiology is very important when you are talking about obstructive jaundice. And what is effect of bile salt obstruction?
Sir, it irritate the free nerve ending in skin, lead to, sir, itching.
Does it get deposited or doesn't get deposited?
Sir, deposited, sir.
Okay. I am taking.
What is the treatment for that? For the itching?
Yes, sir.
What will you give for itching?
Also deoxycholic acid.
Only?
and levocetirizine.
And see, usually when it is deposited and it there is a difference in other itching. Here, patient will have day and night itching. That is most important thing. Patient cannot sleep even because of itching. And second thing, whenever there is a itching, cholestyramine is a drug of choice. That is more effective. But as it is more costly, we usually give ursodeoxycholic, antihistaminic, as well as local application.
Calamine lotion was suggested.
Calamine lotion with paraffin.
Paraffin.
That is better. And it
Yeah.
is frequently applied. Okay.
So anybody would like to ask anything? We can go on and on. Apurva?
We go back to the case, sir.
Pardon?
We go back to the case. You are right.
That's right. But remember,
Theoretical. It was little bit theoretical discussion.
but it
Yes.
was important.
No, madam, this was very much required. છોકરાઓને
Yeah.
એવું છે કે આપણને વિપર્સ જ પૂછવાના છે.
Exactly.
So
I
the
am
idea
repeating, I
is that-
intentionally did this, though it looked like I am going in too much of detail, but your mindset should change. You are pre-biased that it is obstructive jaundice and I will be asked only about obstructive jaundice. Nothing else will be asked. That is the biggest.
Lakshman Bhai, will you like to ask something? Lakshman Bhai, I
Yes,
want
sir.
to hear a question from you.
But perfectly, it's going well. The only thing is, sometimes teacher should understand that whatever student is saying is also has some legitimate scope, as he
Yeah.
said that pre-hepatic, hepatic, and post-hepatic. That's fine.
Fine.
Hemolytic, infective, and obstructive. That's fine. All the three and similar pre-hepatic, hepatic, and post-hepatic is equally same as hemolytic, infective, and post-hepatic, right? So, hello.
Yes,
Yeah,
sir. Yes,
but
Yes,
the
you
problem,
are audible.
yes, you're right.
Point well taken.
Absolutely.
So I think we should give some leverage to student.
Yeah.
Okay, fine. He is okay with that.
Yes,
We should not
Fine.
stick to the words. He should say infective only. Or it can be hepatic. Fine.
Hmm.
So
yes,
little
yes.
bit is fine, I believe.
The only
Yes.
problem is that examiner will understand that it is only regarding the obstructive. Or
Yeah,
it is more,
true.
more in a
Sir,
case of
I-
serotic and non-serotic.
To be
So
frank,
normal.
in exam there won't be much much time, so this point will at least be asked continue at least for 1 or 2 minutes usually. So he should, and whatever he says we should accept also. Otherwise there is no yes.
Yes.
Agree. We should also
Okay.
learn from this. Yes, very good.
Yes. Okay.
Okay, just to add one more thing.
Yes.
Instead of saying infective jaundice, better word is hepatocellular jaundice.
Hepatos. Yes.
So that it
Point
will
well
include
taken.
drug-induced, toxic, and other
Yes.
things also.
Yes, you are right. Perfect. That's why we call so many people. Perfect. The better word is hepatocellular. Right.
But any word should be accepted at the same time in PG surgical PG exam.
Yes.
And just one more
Let
thing,
us
hepatitis
go to
A
another
can cause
point.
both type of jaundice, hepatocellular and along with that cholestatic. Cholestatic is kind.
Let us go to next slide.
Yes.
Yes, I think we have discussed this part.
Let us go to examination.
Now start examination, Dixit.
Yes, sir. General examination. I have examined my patient in adequate light exposure with consent. Patient is conscious, oriented, well oriented to time, place, and person. Patient is averagely built and nourished. Temperature is normal. Pulse 90 per minute in regular with normal rhythm and volume. Blood pressure 110 by 17 mmHg in right brachial artery in supine position. Yellowish discoloration is seen in sclera and under surface of tongue. No pallor, clubbing, cyanosis, generalized lymphadenopathy or edema. Back and spine normal. No signs of liver failure. On inspection, abdomen is flat, umbilicus centrally located and inverted. No visible fullness, no scar, dilated vein, visible peristalsis or abdomen. All four quadrants are moving equally with respiration, and hernial side normal and external genital area normal. On palpation, abdomen has normal temperature and no tenderness, no guarding or rigidity. Liver is palpable in right hypochondriac, epigastrium, and right lumbar region, 2 cm below the right costal margin in mid-clavicle line, non-tender with smooth surface, sharp edges, firm consistency and move with respiration, and a well-defined globular swelling of approximately 4 by 4 centimeter size, palpable in right hypochondriac region in mid-clavicular line, at lower border of liver, non-tender, smooth surface, firm consistency and move with respiration, no other palpable lump or organomegaly, no palpable left supraclavicular lymph node. Liver span is 13 centimeter in mid clavicle line and 15 centimeter in mid axillary line from fifth intercostal space. Dullness is present over the above mentioned lump, which is continued with liver dullness. No free fluid present. A normal Walsh peristaltic sound. On rectal examination, clay color stool present. On systemic examination, cardiovascular system, central nervous system, respiratory examination, and abdominal examination normal. Case summary: a 50-year male patient presented with progressively deepening jaundice for 1 month associated with clay color stool, anorexia, loss of weight, and generalized itching. On examination, gallbladder is palpable, non-tender, with hepatomegaly 2 centimeter below right subcostal margin, with clay color stool staining in rectal examination.
Go to first
What is
slide.
Courvoisier law? What is Courvoisier law?
Madam, let us finish some fallacies in slides. Let us go to first slide
Okay,
of
Yes.
examination.
first slide.
Yes.
Okay. See here, you should not mention only averagely built and nourished. In PG exam, you should go for some scores for benign and BMI and these scores, right? One suggestion, go to next.
Yes.
Okay, still you can go next slide. Just some things which I found to be, see here at least I can see some fullness on left hypochondriac and lumbar region. This is what I can see. Umbilicus does not seem to be inverted, right? This is what my take on this picture is. I may be wrong. Next. See here also you can see some fullness on the left of umbilicus. This is what my observation is. Next. Yes, one more thing. 4 by 4 centimeter size palpable globular swelling in hypochondriac region. Do you know how much is the dimension of hypochondriac region? It is very small. It cannot be only in hypochondriac region. These are the points which we take it very casually to mention, right? Usually when gallbladder is palpable, it at least extends into lumbar region. Many a times it goes into iliac fossa as well. Just to keep it in mind. You just draw right hypochondrium and it is very small triangle, right?
Yes, sir. Yes,
Just
sir.
do it after the discussion is over. Okay.
Yes.
Next. Okay. Next slide. You should mention other than that, rectal examination is normal, right? Because that will rule out the palpable nodule, etc. Right? Okay, now you can go to the first slide examination. Carry on, Nina Ben.
What is Courvoisier's law?
Yes, ma'am. In painless obstructive jaundice, palpable gallbladder is seldom due to gallstone. It is likely due to malignancy.
Why do you say painless?
Because, ma'am,
It is a law. You should start with in a jaundice patient. So whatever is written into the book, you should speak like that only. What is the fallacy? What are the fallacies for Courvoisier's law?
yes, ma'am, double impacted stone, one in sir gallbladder.
What do you mean by double impacted?
Yes, ma'am. One in gallbladder, next cystic duct, and other is in common bile ducts, ma'am.
Okay, then
Yes, ma'am. Second is, ma'am, Mirizi syndrome. Third is, ma'am, hilar cholangiocarcinoma, and third is oriental hepatitis.
all these are not common. So you should say common causes, particularly. That if it is a pyocele, if it is mucocele, right? Like that.
Yes,
If
ma'am.
there is a sloughing of the tissue at the ampulla, that also gives rise to this type of palpable gallbladder or absent gallbladder. It is not palpable, right? What is waxing and waning type of jaundice?
Ma'am, in ampullary variety of periampullary carcinoma, there is a tumor necrosis occur, which tumor necrosis occur and which lead to, ma'am, opening of the ampulla, ma'am. So jaundice was increased and then decreased, but not touched to baseline.
So in which condition it will touch to baseline? The patient is having jaundice, then again a jaundice, but it touched to the.
Yes, ma'am. Acute cholangitis, ma'am.
Or CBD stone, right? There is a one attack, then again patient becomes normal, then again there is a jaundice, like that.
Yes, ma'am.
Okay. Okay.
Lakshman?
Hello.
Yeah.
Yeah. So in intermittent jaundice, what are the differentials? He said one is tumor necrosis at the periampullary region. Then?
Yes, sir. Then CBD stone, sir.
What is Charcot triad?
Yes, Charcot triad is intermittent pain in right hypochondriac region, intermittent jaundice, and intermittent fever, sir.
In this case, is it there?
No, sir. No pain and sir fever.
So no fluctuation in jaundice here.
Yes, sir.
Okay, good. So what is your provisional diagnosis then?
Yes, sir.
What? Yes.
Yes, sir.
What is your diagnosis?
Provisional diagnosis.
Yes, sir. My probable diagnosis is obstructive jaundice, likely due to malignancy, probably due to periampullary mass. My differential diagnosis is cholelithiasis with choledocholithiasis. Second is, sir, Meiji syndrome.
PRM, sir.
Why Meiji syndrome?
Because in Meiji syndrome there is a impaction of stone in gallbladder neck or cystic duct compressing the common hepatic duct or common bile duct, lead to, sir, obstructive jaundice with palpable gallbladder.
In such a short duration of 1 month? And with that significant weight loss?
No, sir. So I kept
Then
in,
why
sir.
differential of Meiji chem? Why? It is always necessary to put a differential? Is it always mandatory? Even in the straightforward cases?
No, sir.
Yes, sir is right. If you are very sure, you may not put a differential diagnosis. Let the examiner ask.
Ask, yes.
So what
Don't
other
carry it
things
away.
you have thought of? But you are absolutely right, Lakshman. There is no need to put a diagnosis. If at all you want to put a differential diagnosis in malignancy itself.
Itself, true.
Yeah.
Stones cannot be justified in a 1 month duration leading to jaundice of such as severity and weight loss also. No one will accept that the stone can be the differential in this case.
Deep jaundice, no fever. Right?
Yes, sir.
Okay. So what
Whenever
is actually... Yes, sir, please.
Whenever
Yes,
there
you
is
were
deep
saying something,
jaundice,
Marcel.
whenever there is deep jaundice, either think of some sort of malignancy or rule out some sort of renal disorder. Sometimes patient is having renal disorder and there is abnormality in excretion of bilirubin, or there is cholangitis.
Yes, sir.
The renal disorder, sorry, I could not get it.
If patient is having CKD, if there is a significant 30, 32 kind of bilirubin.
Again, here the duration is just 1 month.
No. I'm talking about generalized case. Any
Okay.
case.
That's fair. That's fair.
Present to OPD with very high bilirubin, never think of stone. Only in few cases, choledocholithiasis can cause high bilirubin in patient of CKD or in case of associated cholangitis. But usually it is not never reaching 30, 32 times.
Yeah.
Only malignancy.
Yes. Point is well taken, but in a longer duration. And the patient will definitely have a history of CKD. That is the point. Right. So what is Courvoisier's law actually?
In obstructive jaundice, palpable gallbladder is seldom due to gallstone. It is likely due to malignancy.
Okay. It is both are written. This is a very trick question. Just go and mug it up. Some examiner like we would like to ask verbatim. You are right. The basic principle is that. Remember, what is the problem with all of us? When the Courvoisier observed this, there were no available investigation. Just understand this point. So that's why at that time it was very useful to know this. Nowadays, it has a very seldom very important significance. But remember, here the crux is palpable gallbladder. So, and it has a very other associated points you should remember. So, Courvoisier's law is not always true, right?
Yes, sir.
Okay. Why there is a palpable gallbladder in malignancy?
Because of, sir, in malignancy, there is a near to complete stricture lead to biliary stasis, sir. And
so stone will also lead to biliary stasis. You will not have such a long time to elaborate. You are gradually picking up. Answer should be small, crisp, and straightforward. Bile stasis is obviously there in all type of obstructive jaundice. What I am asking you is why there is a palpable gallbladder in malignancy?
Because of, sir, there is a complete obstruction in malignancy.
No. Because there is no previous cholecystitis, cystic duct will be patent. Associated with complete obstruction, there will be palpable gallbladder. Here the important point is there is no cholecystitis, and that is the crux of Courvoisier's law. It understood that that patient did not have a cholecystitis, and now palpable gallbladder without pain and anything likely to be malignant. So here the unaffected patent cystic duct is very important.
Yes, sir.
Do you get that point? So
yes.
Why do you say this is gallbladder? What you are palpating is?
Because it is a continue with liver and move with respiration, and dullness of liver continue with dullness of dead mass, which suggests.
So that is liver cyst. Any liver cyst will have the same criteria.
So you should say this shape of this swelling. Globular swelling.
Yes, sir.
Move side to side, not up to down. Not up down. Like that. Okay.
Yes, ma'am.
Any other reason why it is gallbladder? In presence of jaundice. In presence of deep jaundice, it corroborates that it is likely to be a gallbladder. Right. So
Yes.
palpable, non-tender gallbladder is important point. Where did you palpate that gallbladder?
Sir, near the tip of 9 costal cartilage, sir.
There is a point. Name is a point. What is that point? It's known as
Murphy's point, sir.
Murphy's point. Right? Murphy's point. So Hitesh sir said one point which you did not understand, I think. We always say right hypochondrium, but we are seldom right, particularly when the liver is also congested and enlarged and gallbladder is down. So how can you palpate it in the right hypochondrium, gallbladder? How can you palpate? So what does the divide hypochondrium and lumbar region?
Yes, sir. Transpyloric plane.
So
sir.
from where does it go?
Tip of 9 costal mark.
Right. So almost
The liver has reached up to there. When you say it is a 4 centimeter, it has reached up to there. So it will be probably lumbar and umbilical region.
It is
right?
mainly lumbar
So
or umbilical
whenever
region.
you say liver is enlarged, right hypochondriac swelling will be less likely, right?
Yes, ma'am.
So it is almost always palpable in right lumbar region rather than in right hypochondrium. Hitesh was saying the same thing. So that we are so used to say always right hypochondrium, always right hypochondrium. You maybe most of the examiner will allow it, but if somebody asks, you should know it is actually in a right lumbar region that you will.
And on the contrary, if you say right lumbar region, the examiner will appreciate that. Other students said right hypochondrium. Whenever it is palpable, it is never never ever in only right hypochondrium. It's a small triangle. Just go and try to draw it hypothetically on patient's abdomen. It is very small.
Yes, sir.
Okay.
It may be possible
Yes.
that only palpable gallbladder rarely may be occupying right hypochondrium some part, but it is always extending into right lumbar region at least.
Right.
So
So again,
are
what
you
are
trying
the
to mention?
causes?
Lakshman, yes, you were saying something.
Yeah.
Yeah, I am trying to make it less clear, matlab better by saying right upper quadrant is a relatively better
Yeah.
presentation rather than just sticking to the
I
lumbar
fully agree, sir.
hypochondrium.
I fully agree, but the academic teachers, only those who are only teachers, maybe they will ask that now you should not use the quadrant word. I fully agree. I fully agree that it should be like that.
Sir, what we used to do is that in history we mentioned right upper quadrant, and in
Yeah,
examination.
this is what I'm. So examiners will, but if as an examiner I'll accept it. That's fine.
Because
That
patient is
leads
not
to
able
one
to
question:
find
what
that
are
nine
the
quadrants.
regions of abdomen, and then you will have to answer.
Yeah.
Yes. So
Fine.
in history quadrants and in examination that 9 quadrants.
Right. So the point here is, Dixit, for
No,
all of the
Dr.
PG
Harshal, I
student
think
is,
in history we don't say right upper quadrant. We say right side of upper abdomen. We don't use
Yeah, that is
quadrant
also
word
fine.
in
Yeah,
exam.
that is also.
so Dixit, what I wanted to say is that whatever you say, you should know the difference. So
Yes.
if you know the answer, you will come out from it. You have said right hypochondrium. I say, Hari, is it right, really in right hypochondrium? Just have a presence of mind to change yourself. Do you
And if
understand?
hint
For
is
technical
given,
words, I can understand.
if hint is given, you should be able to catch it up. Sorry, sir, I should have used the word right lumbar as well, or it was my what of not in my knowledge or whatever word you say.
Whatever word you, but you just be ready for this kind of
rectified.
that. Yes, fine, right? So,
Yes.
so experts, what is your opinion now? What we should you go further? What you, Nitesh bhai, anything else you would like to ask in examination?
No, sir. I think we should go for further discussion.
Have you mentioned scratch mark? Just I wanted to be general examination. Just go back. I was not there at that time.
No, sir. I didn't mention because no, I did not see,
Remember
sir.
this, you should mention it in general examination
If it
when
is,
the patient's
if they are
primary
present.
complaint is itching. It should not be missed. Do you
But I
understand?
think probably they are not seen.
Maybe. So you should say scratch marks are not seen. The point here is that whether they are present or not, you look for it.
Yes, sir.
When you are saying itching, you should always look for a scratch mark, which is a very important point in that condition. Right. Okay.
Yes.
It is, I would say that it is an inverted umbilicus, according to me. I don't know.
Yeah, yes, sir.
There
In
is-
this picture it seems, but if you see the other picture, show me the previous slide, there it
Yeah.
looks little different. That's why I said yes.
But there is a definitely some fullness, that is for sure.
This is a two-dimensional view, so we are not in
Able to
this
say, yes,
picture.
exactly.
I agree in the other picture. That's fine.
Another important mistake you have made is, what do you mean by all four quadrants are moving equally with respiration?
Because, sir, in acute cholecystitis,
But
there
you
is
are talking of 1 month complaint. So there is no question of acute cholecystitis.
Even if there, how the four quadrant will move with respiration?
Yeah, agreed.
What is that?
because there is a decreased movement of abdominal wall due
How
to
did you see the lower quadrant movement? So the point here is that you know what is damage control. This is another art to be learnt in exam. Sometimes we all, even today, I also make the same mistake, right? But you should, if examiner asks you and give hint, you should immediately, oh, this is some goof up. Sorry, I should have said upper.
Proportionately, all quadrants move proportionately.
And the better word is simply
tag mark. What is that tag mark? White tag mark in right hypochondrium and umbilicus region. I can see something written in a hazy white background. Is there anything written?
English. I can use
English.
the word English.
Yes.
I don't know. What is it? I don't know.
Is it a net picture or what?
No, sir. In my desktop, sir, there is a.
Okay, fine.
English.
That's fine.
This is another important point. It's okay. It will not come in picture here. But when you are present, use your own pictures. That is the point which is said. Not for the exam, but overall. That is another important point. Right. Go back next.
Yes.
I tell you, sir, I went for one national validation of question, and someone brought his own question of internet. So I asked, and that was simply daily used gadget in words. So I asked my student to take picture and send me it in HD. This is what happens even with teachers.
Yeah.
Sir, everybody has habit of grabbing it from internet rather than having. We have enough material in our hospital. Why not to take our own pictures? This is fine. This is not for you, Dixit. I agree with you. This is your own. Carry on.
Palpation.
Yes.
Go back. Go further.
I think examine.
No, just one point. Percussion.
Yes.
Yes.
Percussion.
Yes. Sir.
Yeah. So you say dullness is present over above mentioned lump, which is continuous with liver dullness. So which lump will have a resonant node, which is there?
Hello.
Yes, you are audible. Continue.
Sir, I did not understand.
So you said lump is dull, you want to say. Gallbladder is dull, you want to say that. You don't understand it. Am I audible?
Yes, sir. Yes,
Yes,
sir.
sir. Dixit, the lump is dull, right? On percussion, the note is dull on the lump, right?
Yes, sir.
So did you really do it?
Which lump is resonant?
Sir, in renal lump, there is a colonic colon above it. So there is in percussion, there is a resonant node present, sir.
So it is known as a band of resonance. Word specific use is a band of resonance, not resonance. Okay.
I would say it is not needed actually. Anyway, doesn't matter. Anyway. More important.
Remember a dictum. Error of omission is always better than error of commission.
Yes. So I don't want to go in detail of that, but it can be a problem. Just I wanted to point it out.
It will be a problem for the candidate.
Yeah.
Then examiner will ask about three-finger test and all these things.
Examiners are leaders of opposition.
Operation Sindur hua tha, like that. Anyway, so I'll be more
read about three-finger test in hydrated cyst. Read about it. It is not done, but if you write about percussion, you examiner will ask you definitely. Okay.
Yes.
Okay.
Next slide.
Don't try to oversimplify or undersimplify anything. Don't use your brains when you are presenting a case. Answer presentation money.
Yes, sir.
You said no free fluid present. How did you decide that? Agreed. I am agreeing. You are run rightly. I am just asking you for other candidates' benefit. No free fluid present. Why did you do this? In this particular case, don't generalize.
Yes, sir. In malignancy, there is a if free fluid means ascites present, then it is not operable, sir.
Arey yaar, this is another problem. You have reached to end of the story straight away. All or none.
If there is ascites, means patient is having spread of disease. That's all.
One. Second, there can be ascites in such cases because of the hypoproteinemia. There can be a presence of ascites because of associated liver disease. There can be ascites because of involvement of the liver. There are so many things in malignancy. What I want, this is you give answer which I can elaborate. It is not necessary. It is malignant ascites only.
Yes, sir.
Keep this thing in mind. You should have an answer that it can be one of these things. Do you understand? But what actually want to know, which test did you do for a no free fluid present for that?
Yes, sir. Sir,
I am just asking because this has become very problematic. Candidate always go for all test, not necessary. Okay, let us see. Which test did you do?
Shifting dullness, sir.
Shifting dullness. Why did you do shifting dullness?
Because Sir, test is positive when fluid is around 400 to 500 ml. So
Remember, for a minimum ascites, apart from puddle test, which should never be done, the shifting dullness will recognize minimum ascites. So that's why the first test you do, if shifting dullness is negative, you don't do any other test. You understand my point? That
Yes,
should
sir.
be kept in mind. Shifting dullness is always answer if free fluid present or not. Sir, I have done shifting dullness test. It is negative. Then say I have also done horseshoe dullness. I have done shift fluid thrill. They are not required. Just to clarify. Do you understand what I want to say?
Yes, sir.
Okay.
Yes.
Lakshman?
Yes, sir. Agree.
Means now should we go for a investigation part?
Investigation, yes, sir.
Anything else? If there's anything you would like to ask?
No, sir.
Okay.
I many times I think that all examiners say that you should mention USG. It's a part of extended examination, and still we stuck up with such a discussion on free fluid different signs. Once he says no free fluid is present, we should continue with the discussion. That's what I believe.
Yes.
Carry on.
Dixit, examination or
Yes,
investigation.
sir.
Okay.
Yes, sir. Yes, sir.
No, don't show it. What will you do? We are asking you.
Yes, sir.
Yes.
Now, this is a clinical diagnosis. You have read. We agree with your diagnosis. How will you proceed? Now, the expert should take over.
Sir, I want to confirm my diagnosis by doing, sir, complete blood count, liver function test, and ultrasonographic USG abdomen, sir.
Agree. Why I want to discuss your differential diagnosis. Why have you kept cholelithiasis with choledocholithiasis? Will gallbladder be palpable in case of choledocholithiasis with cholelithiasis? Usually, why should you keep it in provisional differential diagnosis? Itching, pale color stool.
Yes, sir.
સાહેબ
Yes, sir.
આપણે ઓલરેડી એને ઠપકારી દીધું એના માટે સાહેબ કે
હે?
આપણે ઓલરેડી ઠપકાર્યો છે કે જ્યારે ડિફરન્શિયલ
okay.
ના મૂકવાનું ને નહીં મૂકવાનું.
Okay. In meningitis,
starting yes, સાહેબ એ જ કહે છે જે પહેલા સાહેબે કીધું again he is reiterating કે when there is no need, you don't need to put differential always. When you are very sure.
So if it is written, you should have said, sir, as per our previous discussion, I will like to put my provisional diagnosis as obstructive jaundice due to malignancy only. You can edit your slides right now in discussion. That is what presence of mind is. Right?
Yes.
Right? Carry on.
Yes.
Next.
Yes,
So what
sir.
will you do? What? No slide. What will you do?
Sir, I want to confirm my diagnosis by doing complete blood count test, liver function test, and ultrasonography of abdomen, sir.
What will you like to see in ultrasonography?
Sir, in ultrasonography, I want to like to see liver status, then intrahepatic bile radicals, extrahepatic biliary.
Yes.
Extrahepatic biliary radicals, and gallbladder status, and common bile duct diameter and status, any stone in common bile duct, and there is any pancreatic, want to see pancreas, and any lesion in head of pancreas, or
what will you like to see in pancreas?
uh,
Suppose
sir,
this is a typical periampullary carcinoma patient. Typical. What findings do you expect?
sir, double duct.
How does radiologist begin his sonography of abdomen?
Sir, in from, sir, epigastric region, then, sir, liver.
No, usually the sonography begins with liver. He always looks for liver, then with echogenicity of liver, usually goes to compare the other organs. This is how he begins. Just go and observe how a radiologist does sonography. Okay. In this patient, what do you expect?
Yes, sir.
First finding to be noticed.
Sir, there is a enlarged intrahepatic and extrahepatic biliary.
Dilated IHBR. Very good. Then hugely distended gallbladder. Then,
sir, enlarged, sir, diameter of common
don't
bile.
say enlarged. Dilated. There is a
Dilated.
difference between
Yes.
enlargement and dilatation. Then dilatation of biliary system. Do you
Then,
expect CBD to be dilated?
yes, sir. And distal CBD was
No, was not. What do you expect in normal patient? Don't think of these patients finding. So
Yes.
usually, what will you see? Dilated CBD maybe up to lower end. This is what you expect. Then
yes, sir. Then
you may not find any stone in this patient. May not. Then
sir,
then
there is
8 or 9 out of 10 radiologists will say that I am not able to see any mass. So what else will you like to see on sonography or read or know from radiologists, which will hint that this is malignant obstructive jaundice? There is one sign.
double duct sign, sir.
Yes. So pancreatic duct sign is very important. Not necessarily if it is not dilated, it is not malignancy, but size of pancreatic duct. Okay. Then anything else beyond this which you want to know from USG before going to CT?
Sir, in meta.
Yes. So
ascites
IHBR and
metastasis.
how does metastasis in liver look?
Sir, nodule with central umbilicus, sir.
What do you call it? Sign? Target.
Target, yes, sir. Targets.
Okay. Then signs of free fluid. Any nodes which can be seen, if at all, right? These are the things you look for in ultrasonography.
Yes, sir.
Okay. Now, next investigation to confirm the to go to the probability of diagnosis. I agreed. Liver function test we will discuss. But
yes, sir.
radiological?
Sir, I from my history and examination, I suspect, sir, malignancy.
No. We have gone for USG. It is suggestive of double duct sign, right?
Yes,
no metastasis, no free fluid. Now what will you do?
Sir, I want to do pancreatic phase CCT contrast Indian CT scan of abdomen, sir. Abdomen and pelvis. Yes,
Okay. There what do you
કિરિયા સાહેબને કી કેવું છે સર? એક મિનિટ, કિરિયા સાહેબને કી કેવું છે?
Hello.
હા, કિરિયા સાહેબ બોલો.
Yes, sir.
With the sonography, the important thing, as you rightly mentioned, the liver and the biliary system dilatation. At the same time, site of obstruction can be delineated with sonography, whether
Yes.
it is mid-CBD obstruction or at the hilar site, or other sites can be judged by seeing at the sonologist. Second thing, lymph nodes are equally important. They can be assessed with sonography.
Yes, yes.
Third thing, vascular
recently-
encasement. Vascular encasement like portal vein involvement or arterial involvement can be assessed with sonography. The sonography is a very important investigation if done carefully. But most of the time, sonologists do not spend too much time on the sonography, thinking that next investigation is CT scan. So why to bother?
Yes, yes. So
But
rightly said, because if there are encasement and
Sir, radiologists come into play. आप ऐसा मत बोले, देख रेडियोलॉजिस्ट आ गए.
I am already, you know.
Good morning,
Deepak bhai,
Deepak bhai.
welcome.
Good morning.
Deepak bhai, welcome.
Yes. Thank you.
ચલો હવે આ અપૂર્વ સારે મને ચૂપ કરવા બોલાયા છે.
અરે હિતેશભાઈ 5 મિનિટ 10 મિનિટ ડિટૂર.
ના just joking.
નહીં I have requested Deepak bhai to be available.
Of course.
He will share the screen how to.
He is my very good friend. I depend on him maximum.
Thank you, everybody.
He will just give you us a highlight of how to read a CT scan for a periampullary malignancy.
Hello, Deepak bhai. Good morning.
Good morning, sir.
We have provided him with the video and the plates of the CT scan.
Yes.
I would like the admin to give him the sharing rights. साहब ने co-host बनाने slide share करा दो please.
Yes, sir.
Deepak bhai, you are the co-host now, sir.
Yes, sir. Now, just for a short, discussion, what is periampullary? Actually, to say what is periampullary region. So it is very important for all the residents to understand. Whenever we use periampullary region, then it includes 4 subsites. No, it is not only head of pancreas, right? So one is head of pancreas, head uncinate process of pancreas, then the ampulla itself, ampulla of water itself. Then the third is duodenum, periampullary area of the duodenum, like 2 centimeter perimeter of the duodenum, that ampulla. And the fourth one is distal most CBD. That is a pancreatic segment of CBD. So there are 4 subsites of periampullary region, to be very specific. And all these subsites have got their, clinical significance as well as that prognostic implication also whenever we encounter any kind of malignancies. Now, whenever the clinical scenario of obstructive jaundice or jaundice will come, right? So the first and foremost investigation would be ultrasound. Ultrasound, like Dr. Khiria said, ultrasound is very good modality, but unfortunately, it is absolutely under-evaluated right now. And that is, I'm very, sad to say that, because most of our sonologist friends, they just spare, maximum 5 to 10 minutes. That's it. On one CT reporting, I at least personally, give at least 30 minutes. For any malignancy case, I at least give 30 minutes for a single case. So we need, and ultimately you are treating that patient. So you are not treating like it is, within 10, 15 minutes you are done. It's not like that. So I am not just a fence sitter, and I am a part of management team actually. So on ultrasound, we can detect, first is gallstones, right? So gallstone, CBD stones, obstructive, whether it is obstructive or not, whether there is a cholecystitis or not. I would like to add one thing. Whenever there is a obstructed gallbladder per se, because if there is a small impacted calculus in the neck of gallbladder or cystic duct, then also you will get some altered these liver parameters. Bilirubin will be altered, even if there is no intrahepatic cholestasis or even extrahepatic cholestasis. So even if there is no obstruction in the biliary ductal system, when there is impacted calculus in the neck of gallbladder, also there will be some kind of alteration in the liver function test. So we have to keep it in mind, because of, I think there is a empyema formation because of impacted cal in the neck or cystic duct. This can happen. Now, ultrasound can detect even a mass lesion in the head of pancreas, distal CBD, periampullary area, and liver metastasis, nodal disease, vascular. Dr. Khiria said that vascular, but many times, even when I was doing ultrasound, we were facing too much of problem, because the arterial anatomy, as you know, hepatic arterial anatomy has too much of variation. I think the celiac trunk hepatic artery anatomy is in the body. We do all angiographies, but only hepatic arterial anatomy has got different kind of variations, and it is a way almost, I will say, if I do 10 CT abdomen in a day, at least 3 to 4 patients I will get some kind of variation. Like it is, see, always celiac trunk bifurcates into common hepatic artery and splenic artery. Then common hepatic again bifurcates into the hepatic artery proper and GDA. Right? And then hepatic artery proper will bifurcates into LHA and RHA. This is a normal pattern. But many times we do see left gastric artery arising from the left hepatic artery arising from left gastric artery, right hepatic artery arising from proximal SMA. Sometimes even entire CHA gets replaced and it arises from the splenic artery. Sometimes RHA is arising from the GDA itself. There are sometimes accessory right hepatic artery. So normal right hepatic artery is there, and one accessory hepatic artery arising from either superior mesenteric artery from GDA.
Sir,
there are so many vascular variations which we can detect by CT scan only.
Deepak sir,
yes,
the
sir.
whole point of doing sonography and enumerating the point was to make the candidate aware these things can be picked up. We can talk about the variation, everything is fine. We know that variations are always there, but candidates should know that sonography can pick up these many things if done carefully. That was the whole purpose.
I agree. Yes, yes, sir. Bilkul, absolutely.
In fact, a sensible radiologist like Deepak Bhai will obviously go for his own sonography finding and then report CT scan. Am I right, Deepak Bhai?
Yes, yes, always. And one thing I always do is I don't get biased by any report.
Yes.
So in clinical practice also, I think it should be the same. Like the previous discussion I was hearing. So we don't have to bias ourselves by just a single finding, or somebody says that this is like this. We have to think on our own. It has to be our own thought process, depending upon the entire clinical scenario, then blood investigations, then imaging, like that. So we
So,
want.
sir, CT scan.
Sorry, sir.
CT scan, sir.
Yeah, CT scan. I'll just show
How
CT
to
scan.
read the CT.
Yeah.
Deepak bhai, please enumerate regarding the CT scan.
Yes, ma'am. Yeah, I will just share my
Slides, yeah.
Can you see?
Yes, sir.
Okay, fine. Unfortunately, I have only two phase in this CT scan. I don't know whether they have taken other phases, but simple. Whenever we do examine for some obstructive jaundice or jaundice per se, always ask for triple phase CT scan, because we have to take plain scan just to see the radio opaque contents, any hyperdense content within the biliary ductal system. As such, CT scan is not a good modality to detect the gallstones per se, because there are very few gallstones which will be radio opaque and which will be.
Deepak sir.
Yes, sir.
Ask Dixit, does he know about what is triple phase CT scan?
Yes, sir. Yes, sir. So Dixit, I think
Yes.
you can ask you can answer that question.
Yes, sir. We first do plain CT scan. Then after giving iodobromide dye, then took a CT scan at 25 second, 40 second, and 70 second interval. First phase is arterial phase, second phase is pancreatic parenchymal phase, and third phase is venous phase, sir.
So is it triple phase then?
Okay, no. I'll just change a little bit. Actually,
Okay,
yeah. After injection, 25 to 35 seconds, we will take first scan is at 25 to 30 seconds, and that is the arterial phase. Okay, the second phase would be at around 60 to 70 seconds. So no need to take in between phase right now.
Yes, sir.
Yeah, first plain, then the 30 second, that will give you arterial phase. And if we go for 60 to 70 seconds, then it will go portal venous phase. So you will even see the hepatic veins also in the same phase. So by that, we can reduce the radiation dose also. And we can have at the same time all the imaging parameters, like we can see superior mesenteric veins, splenic veins, splenoportal confluence, portal vein, and hepatic veins. And again, in liver, I will say, the previous discussion, Dr. Andharia asked you what is that sign of that metastatic liver metastatic disease. So you said it is a target lesion. So target lesions are very well seen on venous phase. That is a 60 to 70 second delay scan. That will be very well seen on that phase only, because sometimes hypoenhancing metastatic disease will not enhance on the arterial phase. So if we take only arterial phase, then we will miss it. And if we take a very delayed phase, then also we may, there are chances that we can miss that liver metastasis. So first, clear, right? Most of the time we do neutral water only. Previously, many times our clinician friend asked us that you give positive contrast. But at our institution, we have our own protocol. We always use plain water only, neutral water for that oral contrast. That is a distilled mineral water only. And we take always plain, arterial, venous, and sometimes delay, like it is a 4 to 5 minute delay. Then it is an actual triple phase.
Deepak bhai, what is the advantage of taking at 4 to 5 minutes? Please explain.
4 to 5 minutes. Okay. Yes. Most of the time, there are hemangiomas in the liver. They are very common tumors. Now we get pancreatic head malignancy and then 2-3 hemangiomas in the liver. Now sometimes they don't show classic enhancement characteristics on arterial or venous phase. So we have to take delayed phase just to see the contrast retention within that lesions, whether they retain contrast or not. If you encounter neuroendocrine tumor of the pancreas with pancreatic with liver metastasis, then also we need to differentiate between the iso-enhancing that pancreatic lesion, hepatic metastasis versus pancreatic hepatic hemangiomas like that. So that is what actual advantage of delayed phase, that is a 4 to 5 minute delay. So actually, if we go for triple phase, then we have to take arterial phase at 30 seconds, venous phase that is a 60 to 70 seconds, and delayed phase at a 4 to 5 minutes delay. So this is a first scan. This is a plain scan actually. On a left
I think
side.
your slides are not shared, Deepak bhai.
Okay. You are sharing screen. એવું મારામાં તો બતાવે છે.
Somehow મને
Yes,
નથી આવતું.
it is
Anybody
seen.
else?
Yes, it is seen. Now
It
it
is
is
seen,
seen.
but very small. It is not a full screen.
So once we enlarge it, it is showing.
I think it
No,
is
no,
seen
I
as a
have
very
full
small
screen.
screen.
I can see provisional diagnosis slide only.
No. We are able to see.
Dixit, you
We
can,
are able
you
to
can
see.
unshare. Dixit, yes, you can unshare. Now it is seen. Now it is seen.
Yes.
There are two side by side, right? Left and
No,
right.
no, no. Yes, yes, seen,
You
seen.
can see, right? So on the left side, this is a plain scan, and this has been written as arterial phase. It is actually arterial phase, but I don't know. And I don't have venous phase or delayed phase. Dixit, do you have that delayed phase?
No,
You-
sir. No, sir. Not
I got
available.
2 phases only. Okay, fine, no
Yes.
issue. So this is a plain scan.
સ્લાઇડ દેખાતી નથી, એકદમ નાની આવે છે.
તમને દેખાય છે અંધારા સાહેબ?
ના ના બહુ જ નાની આવે છે સ્ટેમ્પ સાઇઝ. If you have
Enlarge કરો, you can enlarge it.
દીક્ષિત તારી પાસે છે એનો કંટ્રોલ? કારણ કે મને તો મેડમને દેખાય છે.
તમારી પાસે વિડિયો છે?
એટલે હું મોબાઈલ ઉપર જોઈન છું ને એટલે મારું એનલાર્જ થાય છે.
હા.
મારા બી ટચ સ્ક્રીન છે એટલે I can also enlarge.
Yes.
સાહેબ અમારી પાસે નથી એવી ફેસિલિટી.
એડમિનમાં કોણ છે? ટ્રાય
Varshil, you manage it. You enlarge the screen.
વિડિયો હોય તો વિડિયો રન કરો. વિડિયો હોય તો વિડિયો રન કરો.
Video, I don't have video actually.
So those who are on the
મારી
laptop
પાસે
can also
icon
zoom.
images છે.
Anyway, carry
Yes,
on.
sir. Yes, sir.
દીક્ષિત તારી પાસે હોય તો તું આપ વર્ષિલને એ
Yes.
અપલોડ કર.
Yes, sir. I have one video, sir.
હવે ઓપન થાય છે?
દીપક તારે અનશેર કરવું પડશે. દીક્ષિત ઇઝ ટ્રાઇંગ.
ઓકે ઓકે ઓકે. પછી હું એને રન નહીં કરી શકું. હું સ્ટોપ કરું ચાલો. ઓકે, આમાં વિડિયો હશે ને?
Yes, sir.
Now it is seen well.
ફૂલ સ્ક્રીન કર દે દીક્ષિત.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
અપૂર્વ નેક્સ્ટ ટાઈમ થી આ બધું પીપીટી છે ને એક્ઝામિનર ને પણ શેર કરી દેવાનું સો ધેટ ઇટ કેન બી ડન નાઇસલી.
રાઈટ સર. ઓકે સર. શ્યોર.
આ વિડીયોમાં છે ને થોડું પેલું ડિસ્ક્રિપ્શન ને બધું થોડું અઘરું પડશે, પણ હું જોઉં. ચાલો એક જ મિનિટ.
Yes. Can I start, sir?
યસ. Dixit, you want to describe or I should describe it?
ના સાહેબ તમે ડિસ્ક્રાઇબ કર્યો એ તમે કહેશો એટલે સ્ટોપ કરી દેશો.
Fine, fine. So this is a lever, right? We do see what we are seeing. Just we will discuss. We are seeing dilated intrahepatic biliary ductal system. Okay, fine. This is a common hepatic duct. Now we are also looking at this is a gallbladder, which looks over distended. This is a common bile duct here. It is also dilated up to the lower end. It looks dilated, right? So this is a head pancreas. This is a pancreatic head. This is a second part of duodenum. Here you can see the narrowing. So now this CBD dilatation has gone, and now it is showing some polypoidal soft tissue thickening, which is projecting into the second part of the duodenum. So this is a very classical case of ampullary lesion. So it is involving only ampulla of water and probably the adjacent medial wall of the duodenum, right? It is involving lower end of the common bile duct, and that's why the CBD is dilated and bilobar IHB are dilated. Gallbladder is over-distended. Here, one thing I want to emphasize is, Dixit, do you find dilatation of the main pancreatic duct? We were discussing of double duct sign, right? So
Yes.
do you think this patient has double duct sign? And if no, then why? And if yes, then why?
Sir, no, sir. If tumor present in the head of pancreas, then double duct signs are seen.
Why? Why ampulla? That MPD opens at where?
Sir, both, sir, distal bile duct and pancreatic duct join to form common channel, and common channel open at major papilla, sir.
Fine. Now, if there is a lesion in the major papilla, right? So here,
Yes.
we are discussing that there is a lesion in the major papilla itself.
Yes, sir.
At the level of ampulla of water, right?
Yes,
Then
sir.
it has to dilate both CBD as well as MPD.
Yes, sir.
Here it is not dilated because the ventral duct opens into the minor papilla. Just go back in this video.
Yes, sir.
Go back. No. Okay, we started from first.
Yes, sir. Yes, sir.
Somewhere here. Back, little back.
Yes, sir.
Okay, fine. This is a ventral duct. Okay. Now go back.
Yes, sir.
We just observe this duct. This is a ventral duct. Back.
Yes, sir.
Okay, this is a ventral duct, right? Sorry, this is a dorsal duct. And I will show ventral duct again, lower down. So there are two ducts, right? One is dorsal duct. So dorsal pancreas is what? From Janu onward, it is a dorsal pancreas, like neck, body, and tail. It is called dorsal pancreas. And head uncinate is ventral pancreas, right?
Yes, sir.
Both the ducts fuse and then forms a single duct.
Yes.
Minor duct obliterates. Sometimes it do gets open. So pancreatic ductal system, we get either a single duct which drains into the main that ampulla of water. We get the bifid ductal system, like the duct of Santorini and duct of Varsang. Both will be present, but out of both the ducts, only single duct will be dominant. So either duct of Varsang will be dominant or duct of Santorini will be dominant. So whatever duct is dominant, it will be larger than the other duct. So that will be the major drainage pathway of the pancreas. In this case, I think there is a double bifid ductal system with duct of Santorini as a dominant duct. So if you see the duct of Santorini, it opens into the minor duct, minor papilla, somewhere here. Now you can run the video.
Yes, sir.
This is a dorsal duct. Dorsal duct, it is coming and it opens anterior to the CBD. Ideally, it has to be here, right? Okay, stop.
Yes, sir.
Stop. And somewhere here you can again. So when there is an ampullary lesion, and if we don't get a double duct sign, then we have to think of the ductal variation. In this case, the duct of Santorini is the dominant duct here, and that is why we don't get the double duct sign. Otherwise, it is obstructing the CBD and obstructing the ampulla itself, right? So in this case, as a surgeon, you may find difficulty while doing PJ stomy. because the duct is not dilated. Now you transect the pancreas at the JNU region, then you will get only 1.4 or 1.5 millimeter prominent duct, right? So that is what the importance is, because now we have to see the common bile duct and main pancreatic duct junction. So sometimes there is a mal junction also. The most of the time MPD and CBD opens at the same point and then forms a very small common channel which has got intramural course in the second part of duodenum, and that opens into the ampulla. Many times we do get longer channel. We do get the side-by-side insertion of the main pancreatic duct as well as CBD. So, and in all these cases, you may find some variation in the dilatation, whether CBD is dilated, MPD is dilated. Sometimes MPD don't get dilated and only CBD gets dilated. Though here we do see a polypodal lesion at the ampulla, which is not involving adjacent organ. Now the four subsides. Any of the lesion will involve any of the four subsides. Okay. So if we do get head of pancreas lesion, then also it can involve main pancreatic duct, it can involve CBD, it can involve duodenum and ampulla, vice versa. The most important point is then comes the second one is if we discuss about the primary tumor itself. So the tumor extent is very important. So first is location, then the extent of the tumor, then comes the adjoining vascular structures. What are the vascular structures it involves? Like here it is supramesenteric vein. So at the level of uncinate process and then posterior aspect of the head of that genu pancreas, we will get supramesenteric vein, and then from left side splenic vein. So that will be a confluence and then forms the main portal vein, right? So main portal vein will be posterior to the neck of pancreas. So this is a very important anatomical location in terms of encasement. So if there is a lesion which is outside the pancreatic head, it will involve the supramesenteric vein, splenoportal confluence, or main portal vein, like that. Then comes the artery. So the most important, I think, encasement would be supramesenteric artery. If the supramesenteric artery is encased by the lesion, now there is a degree, if we do get 50% arc of contact with the artery, supramesenteric artery, then the surgical decision would be more crucial. If it is 20-30% or so, sometimes, and the lesion is just abutting the vessel and not causing any kind of narrowing of that lumen, then it falls into the operability. But when it is a 180 degree, 50% of the arc of contact, then I think Dr. Khiria.
Yes.
If the tumor is encasing at least 180 degree of the artery SMA or 50% arc of contact, then I think it
Unresectable.
Operability, right, sir?
Yeah.
Okay, fine. One more important point in pancreatic head malignancy, very specific. Many times that is very missed, and then it turns out to be, because it falls into the negative laparotomy. Pancreatic head lesions has got very much, neurotropic affinity. So pancreatic head lesions spread in the perineural pathway. So there is a perineural spread of the disease. So there are two plexus. I will not go into the detail, PLX1 and PLX2, which leads to the pancreatic head malignancy spread along that neural pathway, and that will be through the superior pancreaticoduodenal artery. If it goes along the superior pancreaticoduodenal artery, then it encases the celiac trunk, because superior pancreaticoduodenal artery ultimately arises from GDA, and then from it is celiac trunk. So that will go towards celiac trunk to encase that vessel. And if it spreads along the inferior pancreaticoduodenal artery, which is a branch of SMA, then it will encase the superior mesenteric artery. So many times this lesion is very small in the head of pancreas, but we do get periarterial end plaque soft tissue thickening. So that is actually a perineural disease, which has spread along the this PLX1 or PLX2 neural pathways. So that is very important point to take into consideration. So it comes arterial, venous, perineural disease, then the direct invasion into any other organs, right? That is the third thing. Then nodal disease, of course, we have to see the whether there is a regional nodes or not. Then we have to see for the distant nodes. So pancreatic head malignancy or periampullary malignancy, the interaortocaval nodes are considered to be regional only. But if we do get infrarenal retroperitoneal nodes, then it is considered to be part of the M1 disease. Then we have to assess for the gastric outlet obstruction, whether the duodenum, if suppose a duodenal lesion is there, primarily duodenal lesion or ampullary lesion, which has invaded the entire wall of the duodenum, pancreatic head lesion, which has encased the second or third part of duodenum, then we do get gastric outlet obstruction. So we have to assess for the gastric outlet obstruction and then the metastatic disease. Pancreatic head malignancy, even sometimes we do get omental peritoneal disease also. So we have to be very careful in assessing the peritoneal metastatic disease. Anything else, sir?
Thank you. Thank you very much.
Thank you, sir. Sorry that you could not share the slides, so that otherwise I wanted it to be a little more informative for our speeches. Anyways, thank you, sir.
Fine. Thank you, sir.
Thank you,
So the
Dr.
question is that this supposing it's a periampullary mass or the mass of the head of pancreas, what would be the investigation of choice?
Okay, at our institution, we always follow triple phase CT abdomen pelvis is an investigation of choice, because as we discussed,
Sahib, Dixit Mate.
Oh, sorry.
Yes, sir. Pancreatic phase CCT A plus P, sir. Contrast intensity abdopelvis, sir.
भाई मैं क्वेश्चन पूछो છે કે CT થઈ ગયા પછી if it's in the head of pancreas, what would be there has to be some other investigation. આપણી જોડે we have Harshal bhai also with us.
Hello.
So the role of endo-UL.
આમાં સર એક તો જો એમ્પ્યુલરી કેન્સર જ હોય ને તો પહેલા તો સાઇડ વ્યુઇંગ ડ્યુઓડિનોસ્કોપી કરીએ અને એની અંદર જો ટ્યુમર દેખાઈ જાય તો ડાયરેક્ટ બાયોપ્સી એમાંથી લઈ શકાય.
Take me, sir. Dixit, this is what I was asking.
Yes, sir.
See, okay, anyway, Harshal bhai, please elaborate a little that how do I mean, why is it better when it is especially the head of pancreas?
Okay, એટલે સર head of pancreas is a different thing, but જો ampullary carcinoma હોય તો first side view endoscopy કરી અને first we see the tumor, we can see the tumor size and all those things. We can take direct biopsy just by side viewing endoscopy. But if it is in head of pancreas, we can do EUS, and EUS guided FNB can be taken for tissue diagnosis.
Dixit, got it?
Okay.
Yes, sir.
Hello.
Yes, sir. Yes, sir. Bolo.
Dixit, now you have the diagnosis of adenocarcinoma periampullary region. What will you do now?
Sir, from CT scan, I do the tumor is operable or resectable, borderline resectable or unresectable. If tumor is resectable, then sir, I first prepare the patient and correct.
How will you prepare?
Correct the sir hemoglobin level, giving sir vitamin K for 7 to 10 days. Then sir maintaining the hydration of patient, then correcting the PTINR of the patient, and after then sir I will go for surgery, sir.
No biliary drainage?
Yes, sir. If bilirubin is more than 15 milligram per dl, then
How much is in this patient?
In this patient, sir, 18. Total bilirubin was, sir, 18 milligram per dl, sir.
Okay, so will you go for drainage?
Yes, sir.
What drainage?
Sir, ERCP guided, sir, stenting, sir.
It is not possible, then what will you do?
Sir, PTC guided, sir, drainage, sir, PTBD, sir.
So one is internal drainage, another is external drainage. Which is preferred, internal or external?
Sir, internal, sir.
Why?
Because, sir, there is less chance of infection.
Who told you this? What is more physiological?
Internal, sir.
Internal. So you establish the bilioentry continuity by putting the stent. So all the physiological derangement will be corrected and bilirubin will come down. Your vitamin deficiencies, vitamin K, all things will be restored. So how much will you wait? How much time?
Sir, 1 week, sir.
1 week? How do you know that 1 week is enough?
I don't know, sir.
Okay, that's good. That's good. It satisfies the examiner's ego. So ideally, one should wait till the bilirubin level goes below 2 or normalize. Once you stent the patient, you have to wait for such time, or the patient develops some complication, then you may go early, but ideally one should wait till the bilirubin level comes below 2.
Yes, sir.
Okay?
Yes, sir.
And anything else you want to do in this patient before surgery?
S- Sir, if its tumor is borderline resectable, then I give some neoadjuvant chemotherapy, sir.
Who? But according to this imaging, this is resectable, not borderline. Why are you going for the borderline? Why do you want to go on that track? We are talking about this patient, na?
Yes, sir. Yes, sir.
So what will you do in this patient? So now the bilirubin has come below 2. Patient is fit for surgery. What surgery will you do?
Sir, Whipple surgery. Pancreatic.
What is Whipple's surgery?
Sir,
Sir,
pancreatic
Kiran, hold on. Sir, just
Yes,
one question. Is there any role of gut preparation? Previously, we used to give everything. So, what is the role of gut preparation before surgery in such cases?
We generally do not give gut preparation in any patient of Whipple's. Previously, people used to give it thinking that it may decontaminate the bowel and reduces the chances of bacterial translocation. But it has not been proven over the time, so most of the people don't use bowel preparation.
Right. Okay, thank you.
And similarly, what about diagnostic scopy before Whipple? Role.
Right.
Yes. If tumor size is more than 3 centimeter, and if tumor location is body and tail of pancreas, so I go first for diagnosis laparoscopy, sir.
Why?
Because in this condition there is chances of occult metastasis present, which is missing CT scan of abdomen A plus B, sir.
So will you do it in same sitting or separate? So most of the people, when they go for diagnostic, they do in the same sitting. Lakshman, would you agree with that or not?
Yes.
It is usually done in the same sitting, and they decide why. What is usefulness of diagnostic scopy?
Sir, if omental or liver mets present,
Any mets or any, what is significance of that?
sir, then tumor is unresectable. So then
No, not unresectable. You are talking of metastasis, doesn't mean tumor is unresectable.
That is an operable disease, but
yes, sir, unoperable. So we go for
it is
palliative
operable.
management.
The metastasis is nothing to do with the local disease, right? સાહેબ શું પૂછી રહ્યા છે? See, involvement of the vessel or portal vein is an unresectable disease, unoperable disease. Metastasis is not a contraindication. I mean, sorry, it does not make it a non-operable disease. But
So what will happen if you find metastasis? What does it suggest? So the point here is that Whipple is a kind of surgery. If there is a presence of metastasis, even if it is resectable, there is no role of doing resectability. So what will you do now?
Sir, if there is a for biliary bypass, I will sir do I will do hepaticojejunostomy, and if
So
there is
again, the purpose of diagnostic scope is defeated then. Anyway, if you are going to do laparotomy and you are going to do triple bypass, there is no role of diagnostic laparoscopy. Understand the point. If you do a diagnostic laparoscopy and you find it is a metastatic disease, what will you do? Will you still go on with the triple bypass?
no sir.
Then what? That's what I am asking you.
Sir, then going for palliative management, sir.
That's right. But what palliative management?
हर्षल मैंने बोला है भाई.
Yes,
Yeah, he is there.
Yes,
What is the advantage of doing laparoscopy?
So you do not submit unnecessarily patient for a triple bypass, which still can happen once in a while. So the dictum is there. We used to do simply directly laparotomy and it found to be non-curative. We simply do triple bypass, right? But nowadays, in the present era, with the excellent gastroenterological tools available, we abandon after diagnosing, send the patient to Ursal. So then what will you do? What is the advantage of doing diagnostic scopy is do not submit the patient to excessive morbidity and mortality of triple bypass in a prism where the survival rate is minimum once you find metastasis. So what will you do then?
sir, ERCP guided stenting, sir.
That's the whole purpose of doing that. What kind of stenting you will do? This is different than Lakshman has asked, preoperative before surgery. Now,
Yes, sir.
તો પેલિએટિવ એઆરસીપી માં કેવો સ્ટેન્ટ વાપરશો એમ પૂછે સાહેબ.
Sir, metallic
Vatsal, you can say a little more and tell the students what is the present scenario in that.
Okay.
And,
Dixit,
and even you can say something about that unusual type of we do bypass
yes,
cholecystogastric or something like that.
So
That
the-
I think your
Yes,
hospital is
now
doing
there are
those
many
things.
avenues.
And the students may not be aware of those things. Those are very important in present scenario. Yes, please.
So the common practice that if we are able to pass the wire through the cannula, through the ampulla, we try to put metallic stent. That is the common practice. But suppose if we are not able to put the metallic stent and not able to do transpapillary drainage of bile, then what are the options? Are you aware any options? Aware of any options?
Yes,
શું
sir.
કરી શકાય?
Endoscopic ultrasonographic guided biliary drainage and putting stents, sir.
Okay. So જો IHBR dilated હોય એટલે we go into the stomach, US probe stomach માં મૂકીએ. We try to identify the most dilated मतलब peripheral radical. We put a needle from stomach to IHBR, pass a guide wire through that, અને એમાં પણ metal stand, covered metallic stand મૂકીએ. So IHBR થી તમારા સ્ટમકમાં આવશે. એ બી એક જાતનું enterohepatic circulation it will ensure. બીજો ઓપ્શન છે ડિઓડિનમ માંથી પ્રોક્સિમલ એટલે જે ઓબ્સ્ટ્રક્શન છે એની ઉપરની સાઈડની CBD માં એક્સટેન્ડ મૂકીએ. That is second preference. તો ડિઓડિનો કોલેડોકો ડિઓડિનોસ્ટોમી. સિમિલરલી આમાં બી એ જ રીતે ડિઓડિનમ માંથી નીડલ નાખી ગાઈડ વાયર પાસ કરી એની ઉપર મેટાલિક કવર્ડ મેટાલિક સ્ટેન્ડ નાખી. ત્રીજો ઓપ્શન છે કંઈ ના થાય તો because there is gallbladder, we can also put a metallic covered stent in gallbladder also.
Yes, sir.
The cholecystic drainage thing. These are the options from our side. આ કંઈ ના હોય તો પછી PTB.
PTBD is the last one, right? So
Yes.
sir has used one word, covered stent, non-covered. What is that, Dixit?
Sir, I don't know, sir.
Harshal, please.
See, usually transpapillary drainage માં uncovered મુકાય. But આપણે જ્યારે transperitoneal drain કરતા હોય, suppose કોલેડોકો ડિઓડિનોસ્ટોમી, તો એની અંદર આપણે કવર મૂકીએ કારણ કે એમાં પેરિટોનિયમ વચ્ચે આવવાનું.
Okay. For how
So
much?
technically, what is the difference? હર્ષલભાઈ, technically what is the difference?
ટેકનિકલી સેમ જ છે સર. આપણે ERCP માં તો આપણે ટ્રાન્સપેપિલરી ગાઈડ વાયર મૂકીએ, એની ઉપર આપણે સ્ટેન્ટ પાસ કરીએ, અને જે ટ્રાન્સ ગેસ્ટ્રિક અને ટ્રાન્સ ડ્યુઓડિનલ જે ડ્રેનેજ છે એ આપણે ERCP સ્કોપથી ના કરીએ, એ આપણે EUS સ્કોપથી કરીએ.
ઓકે.
જ્યારે ERCP થી કરીએ ત્યારે ERCP સ્કોપ પેપિલાની સામે ફેસ કરતું હોય. વી સી ઇન ધ ફ્લોરોસ્કોપ, મતલબ ફ્લોરોસ્કોપમાં આપણે જોઈ શકીએ કે વાયર કઈ બાજુ ગયો છે, મતલબ હાઇલમની ઉપર લેફ્ટ કે રાઈટ સિસ્ટમમાં. બીકોઝ હાઇલમ ઇઝ પેટન્ટ, તો કોઈ પણ એક જગ્યાએ વાયર પાસ કરીને કોઈ પણ એક જગ્યાએ આપણે સ્ટેન્ડ મૂકીએ, ધેટ વિલ બી સપોઝ આ ટ્યુમર ઉપર હોત, હાઇલમ અફેક્ટ હોત અને લેફ્ટ અને રાઈટ, તો પછી એ કેસમાં લેફ્ટ અને રાઈટ બંનેમાં આપણે એક સ્ટેન્ડ મૂકવો પડે ઇન આઈડિયલ વે. ઘણી વાર એવું થાય કે બે જગ્યાએ ના મુકાય, તો વી ટ્રાય ટુ ડ્રેન એટલીસ્ટ 60% ઓફ પેરેન્કાઇમા ઓફ લીવર. તો રાઈટ એન્ટિરિયર પોસ્ટિરિયર બંનેમાં ક્યાં તો સ્ટેન્ડ જતા રહે, અથવા તો રાઈટ પોસ્ટિરિયર અને લેફ્ટમાં એક જાય. તો વી ટ્રાય ટુ, મતલબ રાઈટ એન્ટિરિયર 30%, રાઈટ પોસ્ટિરિયર 30%, લેફ્ટ લોબ 30% અને કોર્ડેડ લોબ 10%, એવું એપ્રોક્સિમેટલી એવું માનીને આપણે ચાલીએ. એટલીસ્ટ 60% ઓફ પેરેન્કાઇમા શુડ બી ડ્રેન્ડ. આ હું હાઇલમ ટ્યુમરનું કહેતો હતો, જસ્ટ ફોર ધ નોલેજ ઓફ દીક્ષિત. But in this case, we have obstruction at the ampulla. So what we need is just to pass that level of obstruction. So CBD માં, મતલબ even short stent would also suffice, જો આપણે ERCPT કરતા હોઈએ.
Yes, sir.
Another thing is that because of good chemotherapy, પેશન્ટનું સર્વાઈવલ આજકાલ વધારે સારું છે કમ્પેર્ડ ટુ પહેલા. તો આપણે આ મેટાલિક સ્ટેન્ટ મૂકીએ, એના પછી ઘણી વાર એવું થતું હોય છે કે ઇન ગ્રોથ ઓફ ટ્યુમર થાય, અને આપણે જે સ્ટેન્ટ મૂક્યો છે એનું લ્યુમેન બહુ નેરો થઈ જાય. પ્લસ પેશન્ટ બીકોઝ સ્ટેન્ટનો અમુક પોર્શન બહાર ડિયોડિનમમાં લગભગ 1-1.5 સેન્ટીમીટર જેવો ડિયોડિનમમાં હોય, એટલે પેશન્ટના ફૂડ પાર્ટિકલ્સ પણ એના આઉટર પાર્ટ પર જામી જાય. તો એ કેસમાં થોડા વખત પછી પાછો જોન્ડિસ વધવા મળે, કોલેન્જાઇટિસ થાય, ફીવર થાય. તો એવું થાય ત્યારે સૌથી પહેલું વી ડુ એન્ડ અલ્ટ્રાસાઉન્ડ ટુ સી ઇઝ ધેર એની કોલેન્જાઇટિસ ઓર નોટ. એના પછી આપણે જો હોય તો વી ડુ અગેન ERCP, અને મેટાલિક સ્ટેન્ટની અંદર ક્યાં તો વી જસ્ટ ક્લીન બાય બલૂન સ્વીપિંગ. મોસ્ટ ઘણી વાર સફિશિયન્ટ હોય છે, અને એની અંદર આપણે બીજો સાદો પ્લાસ્ટિકનો સ્ટેન્ડ નાખી દઈએ, મેટાલિક સ્ટેન્ડની અંદર પ્લાસ્ટિકનો. સો ઇટ વિલ મેન્ટેન ધ પેટન્સી. યુઝ્યુઅલી પછી એમાં વાંધો નથી આવતો, અને જ્યારે ઇન કેસ માનો કે એ પણ ઓબ્સ્ટ્રક્ટ થઈ જાય, બીકોઝ કે કોલેલિથોજેનિક બાઇલ હોય આ ટાઈપના પેશન્ટ્સમાં, તો પછી વી કેન એક્સચેન્જ પ્લાસ્ટિક સ્ટેન્ડ મલ્ટિપલ ટાઈમ્સ, મહિને, 1.5 મહિને, 2 મહિને, જ્યારે બી પેશન્ટને સિમ્ટમ થાય. મેટાલિક સ્ટેન્ડ ત્યાં જ રહે. અનધર ઓપ્શન ઇઝ ટુ પુટ અનધર સ્ટેન્ટ ઇન ટુ સ્ટેન્ટ. જો ઇનગ્રોથ બહુ જ વધારે હોય તો મેટાલિક સ્ટેન્ટની અંદર બીજો સેમ્સ મૂકાય.
That's the question I was going to ask, but you already answered. How much time will it take for the blockage of stent?
Sir, આ જે છે ને, it is very varying patient to patient. Some patient may remain well even for 3, 4, 5 months. Some patient may come up with blockage even after 2 months or 1 month. So whenever it happens, we do it.
Okay, thank you.
So serial monitoring of LFT, patient ne pain છે, fever છે, मतलब we have to tell the patient કે wherever you get fever, you just immediately come here, because mostly cholangitis is distance.
Lakshman, you were asking something now. Please carry on.
No,
About
it's
surgery.
fine. Absolutely normal.
Whipples.
Whipples, about Whipples, you can. There is a one question, Dixit. Did we discuss biopsy? Why we didn't discuss biopsy in this case?
Sir, in resectable tumor, we did not take sir biopsy. Yeah, biopsy
Why?
on biopsies are only required for new adjuvant chemotherapy and palliative management for.
The question is why? Why?
If it is an ampullary tumor, it is easily seen in endoscopy.
Lakshman, please answer him.
Then why not to biopsy? If it is visible, then why not to biopsy?
Yes, sir.
Before any surgical intervention, the dictum is you should establish the diagnosis. And Whipples is a major undertaking. And in the past, up to 10% patient may not have malignancy and they were subjected to Whipple surgery. And the complication rate of Whipples is around 15 to 20% worldwide. And the mortality is almost 5%. So one should try to establish a histopathological diagnosis before undertaking this surgery. Always.
Yes, sir.
Even if it is resectable, you have to take biopsy. You have to prove it that this is a malignancy.
Yes, sir.
Then why you said no, it is not required in resectable patients? Anywhere in the body, you need biopsy. Even in the colon, you know that this is a resectable disease, but still biopsy. Stomach, gallbladder, wherever it is, always biopsy. Liver is the only site where transcutaneous biopsy is contraindicated. Rather, gallbladder and the liver are the sites where it is contraindicated because of fear of spread along the needle track. So EUS has been introduced, and now EUS guided biopsies can taken through the paths which were removed in the surgery. So that is a better approach rather than transcutaneous biopsies in the liver and gallbladder.
Yes, sir.
So previously, basically, because when EUS was not there, CT guided biopsy was difficult considering what one is Dr. Khiria said. And secondly, because portal vein and hepatic artery and everything is all by the side. So we are afraid of injuring all those structures. But now with EUS available, I think
one should
can
establish the
biopsy
diagnosis.
all the tissues. Right, sir?
Yes.
So,
Tissue pathology is a must.
Yes, sir.
we should discuss now about Whipple. Dr. Lakshman, will you like to say something related to Whipple?
Whipples is a straightforward surgery, fixed steps and fixed reconstruction. Barring few controversies like reconstruction PJ versus PG, duct to mucosa, dunking, these are the controversial issues. So these things will be addressed as per your training. Wherever you trained, you do that way only. Don't deviate from that to ensure good outcome.
So what are those 6 steps in anastomosis?
So the first thing is exploration, whether it is open, laparoscopic or robotic, whatever. There are 3 techniques by which we can do a Whipple surgery. One is by conventional open technique, that is the gold standard against which everything is compared. Second is laparoscopic and third is robotic. The essential steps will remain the same. You do the diagnostic procedure, exclude adjoining area involvement or distant metastasis, the first step. Second step is to mobilize the duodenum, that is extensive cauterization, cattle brush maneuver, left, right colon, and the duodenum is mobilized up to the superior mesenteric vessels. Take up everything in your hand, then create a preportal tunnel to again establish that portal vein is not involved anteriorly at least, so that you can create a tunnel between a pancreas and the portal vein. Then go up, remove the gallbladder. Above the insertion of cystic duct, CBD is transected. You lift the CBD, come down. Now it will expose the gastroduodenal artery. You take up the gastroduodenal artery, ligate it, transfix it, whatever way you want to do it. Then it will expose the anterior surface of the portal vein supraduodenally. Now your tunnel is complete. Now you loop the pancreatic neck with the umbilical tape or UC tape, whatever you want to use it. That is fine. Then go down infracolic compartment, identify the duodenojejunal flexure. From there around 15 to 20 centimeter downstream, transect the jejunum, ligate the mesenteric vessels up to the head of the pancreas, then deliver the transected part on the right side behind the vessels. Now you put stay sutures on the pancreatic superior border and the inferior border where the vessels run. Now transect the pancreatic head, and lateral tributaries entering into the pancreatic head from the portal vein are sequentially ligated. Then comes the uncinate process. It is released from the superior mesenteric artery and specimen is delivered. After that, you establish the hemostasis, check for everything, then prepare the limb, make an retrocolic loop and bring it in the supracolic compartment. Then establish a pancreaticojejunostomy. We do pancreaticojejunostomy duct to duct mucosa, and osmosis interrupted with PDS 5O and pancreatic ductal stenting with 5 French infant feeding tube. So this is the first anastomosis. Then second anastomosis will be hepaticojejunostomy. These days we started doing with the continuous vicarial sutures. Previously we used to do interrupted sutures of hepaticojejunostomy, and the final anastomosis is gastrojejunostomy. I do feeding jejunostomy in all patients irrespective of their outcome to establish gut feeding as early as possible in the postoperative period. This is what we do, sir.
Very nice.
Apurva,
Yes, sir.
anything else?
દીક્ષિત શું ખબર પડી સાહેબ બોલે આમાં?
બધું લખેલું છે બુકમાં, ચિંતા ન કરીશ.
So what is the role of triple bypass? Previously, it was a very common surgery being done. Nowadays, practically, it is abundant. Most of the time, we don't do. There are exceptional cases. Means by chance you have opened up and found it to be inoperable in that on table or metastasis which were missed. You can go ahead with the triple bypass. That is the only. Otherwise, if the preoperative diagnosis is clear, straightway stenting is a preferred method in today's scenario. And to reconfirm, role of US is becoming more and more evident. Keep this thing in mind. There is one more thing we should not discuss. The point is that role of triple bypass in context with the cost effective, but we'll not discuss it. And in exam also don't mention that. Previously, we used to say that it is cheaper, need not change but morbidity is much higher. So avoid as much as is possible. Unless you have already opened up and there is no other way, because the chances of leak and morbidity is still more with triple bypass.
So,
yeah, I think we should stop, Apurva, now, because otherwise it can go on, right? Thank you very much.
Thank you.
And happy Surgeons Day to each and every one of you. Thank you.
thank you, sir. Same to you. Same to
Thank
you.
you, everybody.
Thank you very
Okay,
much.
we'll leave that. Thank you, sir.
Thank you, sir.
Bye.
Thank you, sir.